Hello, everybody. Welcome to the National Forum on World Ankylosing Spondylitis Awareness Day, organized by Voice of Healthcare and powered by Zydus. So, this episode 2 is focused on the topic of future of rheumatology, advances in ankylosing spondylitis therapies. Today we are going to discuss all the advances in ankylosing spondylitis therapies that are available in India and what would be the future of this in the upcoming years. So the purpose of this panel discussion is to raise public health awareness so that more awareness is generated on this topic on World Ankylosing Spondylitis Awareness Day. To deliberate more on the same, we have some expert panelists here with us today. Please let me start by welcoming Dr. Shailaja Sabnis, who is the consultant physician and rheumatologist at Nanavati Max Super Speciality Hospital and Holy Spirit Hospital, Mumbai. Welcome, ma'am.
Thank you.
I welcome Dr. Nachiket Kulkarni, who is the consultant rheumatologist at Shubhanand Clinic, Pune. Welcome, sir.
Good evening.
I welcome Dr. Girish Kakade, who is the consultant rheumatologist at Sahyadri Hospital, Pune. Welcome, sir.
Thank you. Good evening.
I welcome Dr. Benzeeta Pinto, who is the consultant rheumatologist at Manipal Hospital, Old Airport Road, Bangalore. Welcome, ma'am.
Thank you.
I also welcome Dr. Smruti Ramteke, who is the consultant rheumatologist at Jasleen Hospital, Nagpur. She'll be with us shortly. I welcome Dr. Anisha Kapadia, who is the consultant rheumatologist at Masina Hospital, Mumbai. Welcome, ma'am. I also welcome Dr. Puneet Mashru, who is the section coordinator and consultant rheumatologist at Sir H.N. Reliance Foundation Hospital, Mumbai. Welcome, sir.
Thank you.
Dr. Sabnis will be moderating and leading this session for us today. I hand over to you, ma'am.
Hello, everyone. Good evening to all the eminent panelists. We have from Mumbai, Bangalore, Nagpur. I think the most of the Western India is probably covered by Voice of Healthcare. Thanks once again to allow us to speak and educate more and more of our patients because we know that more than 1 million cases of ankylosing spondylitis are diagnosed every year and maybe more are yet to be diagnosed. We all know that all over the world there is a gap between the onset of disease and actual diagnosis, and even later when the actual patient goes back to the rheumatologist. So, what are the flaws? Where are we going to improve ourselves, and what has improved over the last 25 years? In fact, among all of them, I think when we started diagnosing ankylosing when I was a student, we were always taught that it was arthritis of the spine. We never knew that there was some term called as spondyloarthropathy. And gradually, over years, we started from giving painkillers to all our patients to biologics and JAK inhibitors. I have a esteemed panel who will tell us what are the various drugs available, what we are using, how helpful we are helping our patients for an earlier diagnosis and a better management in therapy. Uh, First of all, I will invite Smruti Ramteke, who is from Nagpur. Hi, Smruti. Good evening to you.
Hi.
Yeah. What are the protocols for our patients for facilitating early diagnosis of AS? Many of our patients, when we read their reviews or their Google questions, they continuously tell us that for 5 years I have had backache. I have been going from one pole to another, but my diagnosis of ankylosing spondylitis was diagnosed much later. So, are there any newer established criteria or newer ideas which we could give the patient?
So, especially from the patient's perspective, Shailaja, ankylosing spondylosis is one of the most underdiagnosed ailments. Sometimes the patient comes with a completely stiff spine and completely fused sacroiliac joints, and then is where the diagnosis is made when he is already disabled. So, from the patient's perspective, The most important thing here is कि never ever uh, underestimate back pain. So whenever you have back pain and you are not getting the proper diagnosis of the back pain, and so you need to be more alert about it and get it diagnosed. So most of the times the patients have a back pain which is inflammatory, and there is where the question comes for the diagnosing doctor as well as the patient. The patient knows that it is a simple backache, but from the medical perspective, most of the times we miss out on the diagnosis of AS. Early AS is rarely diagnosed, and what most of the studies have shown that the span of around 5 to 7 years goes off before the patient is diagnosed. So the most important thing here is know from the patient's perspective that if you have a back pain, अगर आपको बैक पेन है तो आपको कैसे पता चलेगा कि ये इन्फ्लेमेटरी या आर्थराइटिस वाला बैक पेन है, ना कि डिस्क वाला बैक पेन है? हाउ डू यू नो दैट? तो अगर आप सुबह जब उठ रहे हैं और आधा घंटा पौन घंटा आप स्टिफ है या अकड़े हुए हैं, सो दैट्स द फर्स्ट थिंग वेरी विच इज अ रेड फ्लैग. अगर आप स्टिफ है, सुबह उठने के बाद आपकी कमर स्टिफ है और आधे घंटे के बाद जब आप काम करने लगते हैं और यू आर मूविंग अराउंड, देन यू फील बेटर, देन दैट्स वेयर यू सी दैट दिस इज अ इन्फ्लेमेटरी बैक पेन या आर्थराइटिस से संबंधित बैक पेन ये हो सकता है. इवन फॉर द डॉक्टर्स, it is the practitioners who are seeing back pain, inflammatory back pain, that is if the patient is stiff early in the morning for more than half an hour and he says that his back pain is relieved once he is walking around and he feels better after 1 hour or so, then that's the red flag. You just see whether this patient has an inflammatory back pain and he might be having ankylosing spondylosis. Second thing, if you are a male, because the ratio is 5:1, so a male who is having back pain, you have to be on high alert. अगर 5 पुरुषों को हो रहा है तो 1 महिला को होता है. तो अगर पुरुषों में बैक पेन हो रहा है और जो इस तरह का बैक पेन हो रहा है कि when they are getting up in the morning वो स्टिफ लग रहा है उनको, बाद में अच्छा लग रहा है, तो ये आपको एंकाइलोजिंग जो बीमारी है वो हो सकती है. That could be. Second thing is
another thing is I would add, Smruti, that also please tell all female patients who are young who are coming to the OPDs with back pain, you also might have ankylosing, because many times it gets misdiagnosed as just vitamin D deficiency or osteoporosis.
Yes, and sometimes they even have an operated disc.
Yeah, so that is very important too.
Yes, so early diagnosis is very important. Secondly, the laboratory parameters like a raised CRP, it might help us. And if we have a high index of suspicion, we go for a MRI, because X-ray will take around 4 to 5 years to have the proper sacroiliitis, which is diagnostic of ankylosing. So go for an early MRI.
Important things again, what Smruti has told us: one, backache, which is more in the mornings, which does not get relieved by taking rest. Night pains, which are not relieved after sleeping. You get up in the early morning because of stiffness. You feel better after taking a warm bath. Is very classical of an inflammatory backache. So please remember that if you have any such backaches, you should meet your physician and as well as meet a rheumatologist in your area. Coming to the next question, Dr. Puneet Mashru, who is in Reliance Hospital, I would like to ask you that do we have a specific blood test, Puneet, to diagnose ankylosing? Because many patients keep on asking, you have something called as RA factor, anti-CCP to diagnose ankylosing. So do you have any specific blood test, and what is the sensitivity and specificity of the test? So if that test is positive, do I definitely have ankylosing, or are there any specificities?
Correct. It's a very good question. So the diagnosis of ankylosing spondylitis is always a combination of clinical features, blood tests like HLA-B27, and also imaging like an MRI, as Dr. Smruti has pointed out. So there's no, you can get a patient of having the gene called HLA-B27 positive, having low back pain, but may not be having ankylosing spondylitis. So it's very important to keep that in mind. There are different ways of doing this gene test, the HLA-B27. You can do it by flow cytometry, PCR. PCR is the best way of doing it. It's important to note that 90% of ankylosing spondylitis patients have this gene positive. So if I do the same test in 100 people who don't have any sort of pain, 6 to 7 of them will have this gene positive. And out of that, only 5% approximately will develop ankylosing in the future. What about if often we get asked by relative, that I have got ankylosing, so will my son or my child get ankylosing? So should I do this test? That's another question that we often get asked. So the answer would be that 50% of them would get the gene positive, and if they have the gene positive, only 10 to 30% of them will develop ankylosing spondylitis in the future. So the answer is that we should not be doing the test unnecessarily. We should do it only if we clinically suspect ankylosing as a diagnosis.
Absolutely.
And
So
as Dr.
I
Smruti
would say
pointed out,
that,
that there are other investigations.
yeah. So it's very important to note that don't get depressed because you're HLA-B27 positive, like Puneet said. It's only a matter of time and symptoms. If the patient has, do you really do the test for your family members? But it's important to note that if you have symptoms and your family members are HLA-B27 positive with ankylosing, definitely think of ankylosing and meet your nearest rheumatologist. The next question would be to Dr. Girish, who is working in Pune in Jupiter Hospital. I would ask you, Girish, that we know that men and women, I think Smruti has already talked, but there is a different frequency which we often see in men and women. And do you see any difference in the disease presentation also? Would you touch on the sexual differences? Girish, you're on mute. Yeah.
Yeah. So as Dr. Smruti Madam has pointed out, in ankylosing spondylitis, the number of males is more as compared to females. But that was when only X-ray as a modality was available maybe 15, 20 years ago. Now, when the availability of MRI has increased, the diagnosis of non-radiographic axial spondyloarthritis, where X-ray is normal but changes are seen on the MRI, that entity has come up, and it has shown that the affected people have equal number of males and female proportion in that thing. So, uh, contrary to the prior belief, now we can see that this inflammatory back pain and inflammatory changes on MRI can be seen almost equally in males and females. But there are a few changes in clinical presentation. First thing is females, the delay in diagnosis is longer as compared to the males because of not so typical symptoms. Sometimes we see females having some atypical soft tissue pains also, as well as with back pain. So wrongly being diagnosed as fibromyalgia, and they have been undiagnosed for many years, more than 10, 15 years, and then ultimately diagnosed by someone. So longer delay in diagnosis in females, and females, there are the other extraarticular manifestations may be seen more as compared to males, maybe inflammatory bowel disease, case of psoriasis, maybe more. In males, uveitis is found more commonly in males as compared to females. So these are the findings from few studies that they may not be applicable totally, but that's what few studies have found. And also regarding disease progression, male sex has been found as the risk factor for disease progression. So the studies have found that in males the disease progresses fast, and there is more chances of bamboo spine or ankylosis in males. That's why maybe in ankylosing spondylitis, male proportion is higher than the females. But in females, even though the progression may be slower than the males, the symptoms, the disease activity could be more than the males, and actually the suffering because of disease is more in females. So disease activity and decreased quality of life is more in females, even though the disease progression may be slightly lower. And again, because of the lack of awareness among doctors that this inflammatory back pain can happen in females as well. Many times, females uh, diagnosis delay is quite more as compared to males. So why this is discrepancy? The few people have tried to see into that. Still, research is going on. We don't know the exact answer, but there are few genetic factors which are different in males and females, and also sex hormones may also have some role to play in these factors. There are studies who suggest that estrogen might have some anti-inflammatory effect. They might inhibit TNF alpha, which is the main pro-inflammatory factor in ankylosing spondylitis. But still, studies are going on. We don't know exact answer why there is some differences, but these are the differences. And we have to remember that females can also have ankylosing spondylitis. They can also have inflammatory back pain, and they also need to be investigated for inflammatory back pain.
Yeah, that is a very important fact which Dr. Girish has said again, that do not ignore females if they are coming with early morning stiffness and backache or with skin rashes. I mean, examination of a patient is very important. Another important thing for patient perspective, what Dr. Girish said, uveitis is basically inflammation of the eye. So the inner layer of the eye could be inflamed, coming to us with a red eye. Many eye specialists send the patients to a rheumatologist, and many of the patients do not know why they are sending them to a rheumatologist, which the rheumatologist could explain further in the further talk. The next question is, what are the different methods of treatment which are currently available? Dr. Nachiket, are you online? So,
Yes,
what are
ma'am.
the various? Yeah, hi Nachiket. Nachiket is a practicing rheumatologist in Pune, Maharashtra, and a very good rheumatologist. I mean, quite aggressive. So, Nachiket, what are the different methods for treating or currently available for ankylosing spondylitis in India, especially since you also work in some parts of rural India?
I first acknowledge the honor to be a part of this esteemed panel. I thank the organizers for this opportunity and also the AS and fighter enthusiasts who are delegate to this meeting. This question has been framed in a very specific way, and everything what are the different options of treatment and in capital India out here is because and disadvantages of the therapeutic picture when we talk of our country. Some advantages being the disadvantages being that we are a very off the pocket country. Patients to spend their patients have to spend treatment of their own pocket, and that brings up restriction on use. When we discuss about treatments, broadly for any disease and more so in ankylosing spondylitis or axial spondyloarthritis, will divide the treatment options into non-pharmacological and pharmacological treatments, and both have equal importance when we are talking of good outcomes. Among the group of pharmacological treatment options available, the armamentarium starts with medicines that are referred as NSAIDs or non-steroidal anti-inflammatory drugs. Drugs belonging to these groups have a bring about decrement in inflammation that is a part and participle of this disease physiology, and decreasing inflammation would lead to decreasing pain as well as improving range of motions or symptoms of the patient. The second groups that come is disease modifying anti-rheumatic drugs. Some examples that would come in these groups would be sulfasalazine, methotrexate, leflunomide. There's some caveat associated with these medicines. Uh, as far as data goes, response to these treatments have not been exhilarating, but our clinical experience in day-to-day practice has shown that these medications are safe as well as effective when used in right context. Uh, Patients of ankylosing spondylitis and axial spondyloarthritis do not only have inflammation of the spine, but rarely also have inflammation in rest of the organs, rest of the joints in form of hands, feet. So there is where these disease-modifying rheumatic drugs would show a more better benefit to help us upon. The third group of drugs which have made radical change and brought about significant excitement in treatment of these group of diseases are the biologics. Biologics are those medicines which are essentially proteins. These proteins are antibodies which are directed against some cytokines which are a part of immune system. It's well understood when we have discussed physiology that this is an autoimmune condition wherein the immune system is inadequately and wrongly activated to hurt our own body. Cytokines are that part of immune system which carry messages between different immune cells. It has been understood that if we could target these cytokines either in form of tablets or medications or in form of proteins which act directly against these cytokines, the response to the treatment in terms of getting benefit in symptoms as well as benefit in the background physiology would be great. So these biologics have come with a promise of having very fast response and a long-term response. They have also come with a promise of being able to, in some way, reverse the pathology or the damage that the inflammation has brought about in the joints. The fourth group of drugs that we have brought as that have been recently included as a part of the armamentarium, as Dr. Sabnis ma'am has had told at earliest, are the JAK inhibitors. The data of use and benefit of these drugs is still into early days, but the early days itself have been very promising. The best advantage of using these drugs are that they are available as tablets, make it easy. uh, Now, when the reason why India, some advantages as far as India is concerned in treatment that we had to discuss was that the biologics, the JAK inhibitors, the DMARDs are in most of the Western countries very costly avenues. But in India, apart from the original medications of biologics
We'll
and
come to it,
JAK,
Nachiket. We'll come to it, Nachiket, in
yeah, ma'am,
just a short time. Yeah. The
yeah.
next question is to Dr. Anisa. Anisa, we had, I don't know whether you were practicing, but till 2005, I believe that biologicals, which Nachiket told was specialized group of injections, were available only to patients who were affording. Most insurance companies did not give us insurance reimbursement, and many of them were only given to only people who were in the higher middle class or in the higher class. So, what was a game changer plan which came about in 2005? What happened was that biosimilars were introduced, and one of the first biosimilars to be introduced was adalimumab. In fact, the original adalimumab was never brought in India. Zydus was the first to launch on 9 December 2004. And from 2005, it has changed the scene in treatment of ankylosing or rheumatoid or psoriatic arthritis. Would you give some light on this topic? So, what is the game changer in therapy of ankylosing spondylitis, what we are seeing now, and how does it do good to our patients?
Yes, ma'am. Thank you, ma'am, for that question. I think that's such a relevant question in our Indian context. I'll just start with a very small patient story, which I think I'm sure all of us have come across on a day-to-day basis. Just few days ago, I met a young man who was just in his late mid 20s and who was diagnosed with ankylosing spondylitis, probably around in his early, late teens or early 20s by an orthopedic surgeon. And at that time, he was told, you have ankylosing spondylitis, you HLA-B27. Yes, the option is a very, very expensive biologic agent which costs, in tens of thousands of rupees. Being a middle class person, he could not afford it. And subsequently, he went into severe depression and he lost his livelihood to the extent that he came to me with his mother dependent on his elderly parents. Now, this is a story which I think we all see on a day-to-day basis, where patients who were diagnosed many years ago were basically told, you either have no option of treatment or a very expensive option. And this has a lot of psychological impact on these patients. Subsequently, since we've had biosimilars in our country, and luckily I think we do have a strong pharmaceutical industry which is not only able to create biosimilars but give us many options also. So, for example, adalimumab, we have so many options in terms of companies which are available. We have options in infliximab, and all of these, where the cost has come down more than 50%, has created a dramatic improvement. We are now able to offer these drugs to not only people belonging to higher economic category, but also to the middle classes. And sometimes if you explain it to the patient that yes, okay, I understand, this is still, even though it is cheaper now, it is still beyond your economic category. But if you go to see that, on one hand you're losing your livelihood, you're not earning anything at all, but if you take this medicine, you are able to earn. The economic sense it kind of prevails and makes sense. So this is how I approach a patient when I feel they need a biologic. I go into the very intricacies of what their profession is, of how many family members they support, and then the cost factor starts making sense versus just telling a patient this is what it costs and you have to take it. So, what is a biosimilar? It's also important to understand for lay people. As rheumatologists, we understand it very well. But biologics were drugs which were, as Dr. Nachiket gave us a very good idea, they are synthesized from living organisms and they are targeted against certain chemicals in our own body. So, because we cannot create the exact same drug, we are able to create something very, very similar, which is a biosimilar. This works more or less in the exact same way, and studies have now proved, even internationally, that biosimilars are also maybe not as good but very, very similar to the original drug. And from the economic standpoint, it makes a lot of sense. So, even when I was practicing in the UK, the NHS also has actually started moving their patients from innovators to biosimilars, and even they see the economic sense in that. And in India, we have access to these drugs, whereas in international countries they have to actually go through a lot of paperwork before a patient goes on a biosimilar. For example, they have to fail 2 types of non-steroidal anti-inflammatories. They have to meet the ASDA's criteria, that means have high CRP, which frankly, as we know on a clinical basis, that may not, a patient doesn't always fit into a box. So I feel in the Indian scenario, on a positive note, yes, we have to pay out of our pocket, but at the same time, we have easy access to these drugs. We have adalimumab and infliximab both available, and now we also have not biosimilars, but we'll probably come to that, the Janus kinase inhibitors, generic drugs also available. So these have totally changed the face of rheumatology in India, and also in many of the developing countries around the world.
In fact, adalimumab biosimilar has been used in more than 18,000 patients, I believe, from all the literatures, more than 25 published trials from all the subcontinent of India has been given for adalimumab. So that has been a real game changer, followed by infimab, which was the biosimilar which was available, and it was also effective. When we talk to patients, it is very important that we explain to them that when you're treating a patient, you cannot just go on anti-inflammatory drugs or oral DMARDs. There are certain better drugs available which can be available to the whole of population. It's not only for the rich. We can approach social workers, certain societies, approach the companies directly to give us the drugs at a much cheaper cost. So this is very important. Secondly, I think the insurance, even if we don't put it into our paperwork, some of the insurance, corporate insurance, also gives us this facility to get money from reimbursement. So this is a very important thing. Now the next question is for Dr. Pinto. We all know that we were talking about ankylosing affecting the spine, the joints. What other organs can be affected? Is something it does it affect even your bowel or your intestine? Does it cause problems to the eyes? Dr. Pinto is a practicing rheumatologist in Bangalore. Can you please shed a light on that? Good evening, Dr. Pinto.
Good evening to everyone who's joined this session. So I think we've discussed a lot about the what we call as the arthritis or the articular symptoms of this disease. But when we look at ankylosing spondylitis, it is actually a spectrum of diseases that we talk about in this group, and that ranges from what we the earlier form of spondyloarthritis, which is now known as the axial spondyloarthritis, which includes the non-radiographic SPA, the one with advanced radiological manifestation, ankylosing spondylitis, psoriatic arthritis, then inflammatory bowel disease, and HLA-B27 positive recurrent acute anterior uveitis. All these form, and reactive arthritis, which all come under this large umbrella of what we call as a spondyloarthritis. So when we look at what causes this disease, and I think as Indians, we're always constantly getting questions about the gut. I mean, in fact, I don't think any OPD session ends without a patient asking you, "Kya khana chahiye, kya nahi khana chahiye? Kuch diet change karne se fayda hoga?" So when we look at this disease, in fact, there is in fact a lot of literature to look at the gut joint axis. So whether to understand whether what happens in your intestines actually influences your joints. So there is it's proven that depending on the studies, a variable proportion ranging from 40 to 70% of patients with ankylosing spondylitis have at least subclinical inflammation, whereas overt inflammatory bowel disease or overt when we talk of IBD, it is a syndrome with loose stools, blood in stools, and intestinal inflammation. Overt may be seen in a smaller subset of patients, but subclinical inflammation is seen in a huge subset. The other extra-articular manifestations that we see is it not just affecting the spine, other joints getting affected, which is pretty common actually. We see in practice, usually the large joints, the knee getting swollen, the shoulder getting inflamed, the ankle. The other areas that get inflamed are what we call as enthesis. The commonest site that patients come with is the heel pain that patients come with, and they feel whenever they touch particular points, usually they're costochondral junctions, they're tender. The spinous, the back at the spinous process, they're tender. So this is something that we call enthesitis. Then there are another articular manifestation, the entire digit getting swollen, that is dactylitis. These are all articular manifestations. Then there's also this manifestation, uveitis, this inflammation in the eye. So other than that, occasional patients can have ankylosing spondylitis or spondyloarthritis in association with psoriasis. So the important thing is to understand here that it's important to treat all manifestation of the disease, to not focus on one symptom and say your disease is okay. That is why it's important to go to a person who actually does a thorough clinical examination, takes a good history, and assesses for all components of your disease rather than focusing on your back. You may go with backache. It happens very commonly in practice that when we take history, we find that one patient has one episode of a couple of episodes of blood and stools, is not gaining weight, he feels there's some problem, and then when we investigate, we find a Crohn's disease there. So it's just about paying a little more attention to the patient, and also for patients to come out with your symptoms to doctors. We can't be always doing, sometimes in a busy clinic, we may not ask you everything. So please, if there is a symptom, do tell your doctor, yes, I have had an episode of red eye, because if you have, because different manifestations may cause us to do a little bit of a change in treatment in terms of what our choice of drug may be in that particular situation. Again, one more question that everybody asks us, can I do something for my gut? Does a probiotic work? Unfortunately, we do not have great evidence in terms of whether we can change your gut bacteria, whether we can do something that can completely, reverse the gut inflammation and that will take away the arthritis. That's only for IBD maybe, where for certain forms of arthritis, if the IBD is controlled, then the peripheral arthritis gets controlled. You can't really changing your diet or being extremely restrictive, taking probiotics, have currently no evidence. Don't torture yourselves right now.
Okay, thank you. It's a very nice answer. Thanks, Dr. Pinto. Now we all know that in ankylosing there are different inflammatory pathways, which actually led us to find the era of biological therapy. Dr. Anisa has already talked to us about the biosimilars. She would explain to us how it has helped in the treatment and prognosis of ankylosing. Anisa, you have already told us about the patients who came from a poorer class of section of societies, and the biologics really did something like magic. In fact, patients who get admitted with severe pain, and once you give them infliximab, they come to us smiling the next follow. So can you just throw a light on that? So what are the
Yes,
various
ma'am.
inflammatory pathways and how do
Yes, ma'am.
biologicals really affect?
Yes, ma'am. So, historically speaking, I think it was in the late 1990s or early 2000s when the first inflammatory molecule that was discovered. I think Dr. Nachiket has also covered it, but just going back to that, before that, our awareness or our understanding of this condition was less. So, like I explained to my patients that, even the term ankylosing spondylitis is no longer used anymore. Ankylosing spondylitis as a term was coined many years ago, when we knew that if we diagnose a patient today, few years down the line, their spine will fuse, because we didn't really have any treatment to offer them. Then in the late 90s and the early 2000s, they discovered that actually a molecule known as tumor necrosis factor, or TNF, is the main culprit behind this disease, and it is this chemical which is present in all our bodies, but it is just at a higher level or works at a sort of a more aggressive manner in a patient with ankylosing spondylitis and causes inflammation in their spine. So years down the line, when this inflammation is unchecked, it is then that they develop ankylosis, which is meaning the fusion of the spine. So I tell a patient who comes to me early that this is not going to happen to you, okay, because your spine will not fuse if we treat it correctly. That means that in 2000s, when they discover a molecule known as infliximab, which blocks this TNF, they were able to not only stop the the adverse effects or the fusion of the spine from happening, they were also able to reverse some of the things that had happened, and therefore that it was a very big thing that happened. Subsequently, over the next few years, we discovered many newer molecules like TNF. We have something known as interleukin 17, we have something known as interleukin 23. Even these molecules, we know that when we block them, we have drugs for them. So these also have. Yes, ma'am. Yes, sir. And so there are many such sort of pathways in our body, many mechanisms and different pathways which we will cover very soon. But the thing is that what we are now looking at is targeted therapy. So more and more we know that even in ankylosing spondylitis, you might have psoriasis, you might have uveitis, you might have spine disease, or you might have peripheral symptoms. So depending on the each patient is different. We have a patient centric approach, and depending on your specific symptoms, we will figure out which molecule or which medicine will work very well for you, and therefore our overall outcomes now are much better than they were, say, about 30 years ago.
Absolutely true. In fact, I tell most of the patients, don't Google and see the fused spine or the patients coming to us with a hunchback. That was a long term ago. I mean, I have engineers, doctors, a lot of people who even dance, DJs, and are working there. I mean, working much more than actually I work, and they are physically quite active. It's also very important note that we all should tell our patients that exercise and physiotherapy is as equally important along with all the biological therapy and the medications. Now coming to Dr. Smruti, already Anisa has talked to us about TNF, but what do you know more about treatment against TNF factors? What are the important things that patients should note? Can they just take one injection and stop it? Or should they really take continuously for how long, and what is the important role in the TNF factor inhibition in treatment in ankylosing spondylitis or spondyloarthropathy? Shruti on mute.
Sorry. As already Dr. Anis had elaborated about the TNF, tumor necrosis factor, is the causative problem which causes these inflammatory disorders related to the spine. Now, TNF inhibitors are drugs which inhibit the tumor necrosis factor, and we have many of them which are available. To name a few, there is etanercept, which is a recombinant TNF, and it is to be used subcutaneously. Then there is infliximab, which is a monoclonal antibody, and it is to be given intravenously. And then we have adalimumab, which is again a humanized monoclonal antibody, and it is to be given subcutaneously. Now, spondyloarthropathy is a group of diseases where you can have the affection of the spine and the eye, and the psoriasis where skin and the spine and the joints all are affected. So with different disease pattern, you use the different drugs. And another thing which has already been spoken about is even the patient's pocket and how much they can afford and for how long they can afford. So we cannot, in our country, as you all know, follow the fixed protocols or patterns of treatment as outlined in the textbooks because of lack of insurances, and the patient has to pay from their own pockets, and sometimes it becomes, the treatment becomes very difficult for them. So it is with great difficulty that they manage. So, and we as doctors have to empathize with not only the patient's pain but also their financial condition, and understand that the patient cannot follow the book pattern of treatment, and sometimes we have to do some jugaad, like it has to be done. So
Basically, what we do is we don't follow a certain protocol which is given by the European or the
Yes.
American guideline, but we can do some amount of time management of the schedule in between the
Yeah.
two injections. But it is also very important to educate the patient that just taking one dose or just two doses of adalimumab, which are subcutaneous, which are on OPD basis, should be taken. And when you are
Secondly,
on these TNF drugs, there are certain tests, Shruti. Can you tell us
yeah.
what tests also should be
Yes.
done before you
Yeah.
take?
Whenever
Because we are
whenever we
seeing
are
a lot of
prescribing,
other doctors prescribing it.
whenever we are doing, whenever we are using a TNF, we have to be alert that these are the drugs which are going to definitely help the patient, but they can have side effects, and because they are suppressing the immune system. So in our setup, the most important of them is reactivation of silent tuberculosis, which we need to be alert about. So the recommendation is to get a Mantoux and a quantiferon TB Gold and X-ray test for all the patients, and even the serology like HIV and hepatitis B, and the sugars, the lipid profile, and the ECG. A basic cardiogram needs to be done in all the patients, along with screening for a silent urinary tract infection. So we need to know everything about the patient.
So
Patient
it is
emergency
always better
status
that the patient comes
before.
to a rheumatologist.
Yes, yes. Before we are using these drugs. Now the use of these drugs is not only limited to rheumatology. We need to understand that dermatologists are using it, and it is being used all over, and maybe more specialties are going to use it. So there is a need to be aware about the judicious use of these drugs. Of course, we cannot follow the definite, as we had already said about the finances, we are not able to follow the book pattern or the recommendations, but we need to enforce and highlight to the patient that this treatment needs to be taken at least for few, maybe if they can afford for a long time, but at least minimum of 6 months, not none, never less than that. So that needs to be reinforced. Patients, when once they are told, they understand the utility of it, and once they get the benefit of it, they understand that this needs to be continued. These are life-changing medications, but we need to be alert, because use and disuse of the drug, though these are the two
We'll
aspects
go
of
to
the
it
same
later.
coin.
Doctor,
Yes.
for just time limitation, I'll interrupt you. Dr. Girish, we talked about TNF. Is there any role of any other axis or any pathway? We have heard something called IL-17 or interleukin 17, interleukin 23 axis or pathway in ankylosing spondylitis treatment. Which patients should we select? Why we should select? Any differences than the TNF? You, Girish, we can't hear you.
Sorry for that. Uh,
Yeah.
so when the research into the pathogenesis of ankylosing spondylitis started, the first molecule that was found to contribute to pathogenesis was TNF blocker, the TNF tumor necrosis factor, as Dr. Anisa has told. So on further research, the other molecules or cytokines were also found. The first one was IL-17, apart from the TNF. This was found more in first in psoriasis and psoriatic arthritis. Their use was started in those conditions, and it was found that IL-17 also is one of the molecules which contributes to pathogenesis of spondyloarthritis group as such, and it has shown that it is more effective than TNF blockers in treatment of psoriasis and psoriatic arthritis. So that they have become like maybe like first line treatment after the NSAIDs and conventional DMARDs in case of psoriasis and psoriatic arthritis. So their response to psoriasis is better than TNF blockers. Recently, they're also shown to be important and effective in treatment of ankylosing spondylitis, and almost as good as, or maybe same as TNF blockers for treatment of ankylosing spondylitis, both for peripheral as well as axial symptoms. So this IL-17 or interleukin 17, this is produced by cells which are called Th17 cells. These are pro-inflammatory cells which produce these inflammatory molecules. These cells are stimulated by interleukin 23. So then thought came whether if we block IL-17, it works. So if we block the prior molecule IL-23, if we block that also, that should work. And actually, IL-23 molecules have worked in psoriasis and they have been being used in psoriasis. But IL-23 blockers have not been found to be useful in ankylosing spondylitis. So still, the reason is not clear. But theory is that maybe IL-17 molecule is produced by other cells as well, apart from the Th17. So that's why even if we block IL-23, IL-17 will be produced by other cells, and the inflammation in ankylosing spondylitis will go on. So IL-23 blockers are still not helpful in ankylosing spondylitis, but IL-17 blockers, secukinumab is the molecule. The newer one, ixekizumab, is also has been approved for psoriatic arthritis. Secukinumab for both for psoriatic as well as ankylosing spondylitis. And this secukinumab, which is available in India, is actually it's not a biosimilar; it's an originator molecule, same molecule which is available. Cosintex is branded as Scafo in India, and it is at par with the price is at par with TNA blockers, or maybe because of some schemes offered by the company, the price is lower than the sometimes lower than the TNA blockers. So it has come up as a good option where the patients have failed TNA blockers, or they had secondary failure because of antibody production, especially the problem with infliximab, and also to some point in adalimumab. The problem is there is production of antibody against these molecules, and the response which patient gets initially gets lost after maybe few years. This problem is less with secukinumab because it's a fully human monoclonal antibody. So the risk of antibody development is quite less, and even though small percentage of patients did develop some antibodies, those antibodies were non-neutralizing. So even though the patients had antibodies, the response was not lost. So again, this is one more advantage which the patients can have. Other thing is this
Nachiket
comes.
will talk to us more on this. That's the next question, Nachiket, for you. That we feel that if I give a patient TNF blocker or maybe secukinumab or any other such drug, do all patients respond to all these drugs? Why do some patients do not respond? And does it do magic to everybody or does it not do? So basically, why do some people respond and why do they do not? And explain how they respond also.
Okay. The overarching principle about how these drugs respond is that they decrease inflammation. Inflammation is the main pathophysiology by which pain, swelling, stiffness, and bone damage manifests in patients of ankylosing spondylitis. By acting on different targets, the anti-TNF alphas targeting TNF and the secukinumab targeting IL-17, we discussed earlier cytokines, by decreasing them, the inflammation comes down. And as the inflammation comes down, the pain, swelling, stiffness, and the bone damage is stopped and in some cases reversed. Uh, all these drugs, IL-17, TNF alphas, though have showed similar benefit, but we know that no two persons are same. Similarly, no two medications are the same. Pinto madam had advised that ankylosing disease, it's not a single disease. So very simple example, some patients might have only axial pain, some patients might have only knee or ankle joint pain, some might have a combination of axial and peripheral pain. So the disease characteristics, the genetic makeup of the patient, the person's own personal preferences, other comorbid conditions that a patient has, that is diabetes, hypertension, hyperlipidemia, our response to all these the decision making about which molecule will be more beneficial, which molecule will be. For example, there are among the 4 TNF alphas available in India. We know that adalimumab and infliximab work against the eye involvement of ankylosing spondylitis. The rest of anti-TNF alphas might not. So, apart from variables of the disease medicines to be used. Lastly, when we keep using a medication, there is some form of tachyphylaxis that a patient goes through. Anti-TNF alphas and anti-IL-17 are both proteins. Whenever any protein is injected in the body for a prolonged period, the body itself realizes it as a foreign particle and tries to develop reaction against that proteins. And hence our own immune system's response against these biologics can later on lead to decreasement in response, and hence we can sometimes switch from one biologic to another when a response of one biologic is not beneficial. Such switch is scientifically allowed, and sometimes a switch back is allowed. So if over time we realize that the second biologic that we have used is now not being beneficial, going on to the first biologic brings about the use. So alluding to our earlier perspective, that it's not only availability of different medications, scientifically applying tenets of utility and strategies of these medications also help in getting good response.
Absolutely true. And we should, as clinicians, also see what the patients have. So it is very important, like Girish has already talked to us. Girish, how will you differentiate? Which patient will I give IL-17? Which patient will I give TNF blocker? Or I'll just continue oral DMARDs? Just in brief, you have already talked, but just in brief.
Yes, madam. Just we spoke that we can use oral DMARD also in ankylosing spondylitis, especially in patients who have peripheral arthritis. That means patient who has swelling in knee, ankle, shoulders. These patients may respond to conventional DMARDs also, like methotrexate, sulfasalazine, have been used quite usefully. But for axial symptoms, inflammation in the spine, enthesitis, where the tendons attached to bones, the inflammation at that point, or dactylitis in psoriasis, these symptoms do not respond that well to conventional DMARDs. So these patients need NSAIDs, non-steroidal anti-inflammatory drugs initially, and if they don't respond to these, or if they need NSAIDs regularly, in that those patients we actually should go for biologic DMARDs. Which biologic to choose is again depends on the patient and the doctor. I feel that most of the rheumatologists are still they use TNF blockers more commonly than IL-17 because it's the older molecule, has been in use for almost now 25 years. We know all the side effects, everything about that. So we are more comfortable with that, and I think that molecule is used more commonly. But there are special scenarios where we can choose IL-17 blockers over TNF blockers. For example, if the patient has concomitant psoriasis, which is quite severe, it also needs treatment in those patients because IL-17 blockers they are more efficient in treating psoriasis. So in those patients, also if the patient has had previous history of tuberculosis. So recently I had a patient who had multi-drug resistant tuberculosis and had recurrence of TB. Initially had TB, got treatment, again TB recurred. This time it was multi-drug resistant TB. Somehow the patient could come out of that multi-drug resistant TB, and ID infectious disease consultant was not at all did not feel that the patient should receive TNF blocker. So in that patient we chose say secukinumab, the IL-17 blocker, and that worked quite beautifully for that patient without causing any recurrence of tuberculosis. So the patient who had history of tuberculosis, the risk of TB recurrence is slightly less with secukinumab than TNF blockers. And also, if the patient has had any TNF blocker, maybe one TNF blocker, then developed resistant to treatment, shifted to another one. So two TNF blocker failures. Those patients can benefit from switching to another molecule rather than going to the third molecule of same group. So those patients can choose IL-17 blocker, and they can benefit from that treatment. Again, this is again a subcutaneous injection once a month in maintenance phase. So again, very good. Patient can take at home. Initially 4 to 5 weeks, he has to take weekly. Then monthly dose is sufficient. And now with more schemes coming, it is the price also coming down. So if the biosimilar of secukinumab comes at
We'll
the price,
get to it in detail later. Puneet, the question to you is, what is the importance of physiotherapy? Do you suggest any difference in the daily practices of these patients, exercises? How important is the role of exercise in a patient of ankylosing, as I told before? So, what do you explain to the patient?
Yeah, so physiotherapy exercises, especially the back exercises, are very, very important for ankylosing spondylitis. We prescribe to all our patients, and many patients do well and go in remission just with a short course of anti-inflammatory and maintain the physiotherapy. It's very important. Physiotherapy has shown to decrease pain, improve posture, and reduce the risk of the dreaded bamboo spine. So risk of fusion reduces with physio. The physio has to be targeted for the disease. So it should be a combination of flexibility, strengthening, and also for chest expansion, deep breathing exercises are also very important. It has to be individualized depending upon how early or late in the disease and the bamboo spine is developed. For example, if somebody has bamboo spine, then we a little bit we have to tell them not to do too much of flexibility exercises because that may cause a fracture, or avoid too much of weightlifting. So it has to be individualized. The other exercise which is very good and helpful in ankylosing is swimming. Swimming is something that utilizes all the muscles of the back, and it is very, very good for patients with ankylosing spondylitis.
Dr. Pinto, are there any lifestyle changes which you would tell these patients? Should they smoke? Should they not? Should they drink alcohol? Should they keep their weight under control? So, what do you want these patients to do when they are getting treated by you as a case of ankylosing or spondyloarthropathies?
Um, so when you look at the specific things like smoking, so actually smoking has not been directly associated with disease activity in ankylosing spondylitis, but I think one has to take a more holistic view and look at the risk and increased risk of cardiovascular comorbidities in any patient with inflammatory disease. So all patients should be advised to make an attempt to quit smoking. The other thing is alcohol. Alcohol in moderation, of course, there has been no relation that has been described. Yet, when patients, if they are on any drugs that can cause hepatotoxicity, mostly we are using sulfasalazine, although the risk is not very much, and the patient can take occasional alcohol. One should keep in mind that there are increased comorbidities associated, and even if they take alcohol, it should be in moderation. Lifestyle modifications, we've already talked about the importance of exercise. In fact, I think this is one disease in which we have trials which have described the impact of exercises, including if a patient wants to use aquatic exercise on land-based, water-based. All these have in fact been compared, and it has been proven in the long term to improve both quality of life as well as have some impact on disease progression. And these should be encouraged, and the patient should be made aware that ongoing inflammation puts you at a risk for future cardiovascular disease, heart attack, myocardial infarctions, and that is why having a good balanced diet, although there has been some evidence for Mediterranean diets and arthritis, but that has not been directly an ankylosing spondylitis. I usually don't advise Indian patients because I think it's complicated and sometimes difficult for the usual patient. But just making them aware of refined carbohydrates and high-fat diets and cardiovascular health, I think is always should be done to every patient with that.
And if patients are on JAK inhibitors, it's very important to monitor the lipid profiles as well, because we have seen with the use of newer molecules, you have high lipid levels. So the cardiovascular risk, in fact, increases. So it's very important to monitor.
Yes.
Anisa and Smruti, I have a question. I have been diagnosed with ankylosing. Should I get depressed or should I do something else? Starting with Smruti.
There is no need to get depressed if you have ankylosing, because a lot of newer treatments and good treatment options are available, unlike what was there 20 years back. So all patients of spondyloarthropathy with all the spectrums, including ankylosing and psoriatic arthritis, and even the patients with the inflammatory bowel disease, they have hope, and they can all lead a very good life with medications and lifestyle changes and exercise.
Anisa, any further comments?
Yes, ma'am. Completely agree with Dr. Smruti, ma'am, that patients should definitely not get depressed. In the sense, I think patients should be positive, because in today's day and age, we have so many good treatments and so many options for them, that whatever their economic, their financial background, we can find something good for them. And also importantly, they should not Google, and they should understand that that ankylosing is a very heterogeneous or very different disease. It affects everyone differently. It's not necessary that they will develop all the manifestations or all the severe effects that they will read online. And as long as they maintain a overall healthy lifestyle, they take their medicines regularly and meet a doctor and follow up regularly, they'll be fine. And I also want to add that a lot of times patients get disheartened when their first line of medicines don't work. But they should understand that as long as they go back to their doctor and tell them that, okay, these medicines have not worked, let us discuss other options. Something or the other good will come out rather than getting disheartened and giving up medications altogether. So that is the one message
So
that
it
I
is
would like
very
to.
important. One is proper follow-up of these patients. Do not stop your medications without asking your doctor. If you are Googling, please ask relevant questions to your doctor. Don't get disheartened at all. In fact, we should have a psychological counselor, is what I feel. It's very difficult in India, but it's very important, I feel, to explain to the patient that you could lead absolutely normal life, you could have children. Only thing is, it's important that you tell your doctor when you're planning the pregnancy. There's no problem in the males to continue their medications. If you're doing any cross-pathies, please let the doctors know. We see many patients coming to us after 5 years. They have stopped our medications and now they have come with a fused spine, and then they ask us for magic therapies. Girish, do you see such things when our ankylosing warriors come back to us after 5 to 8 years, and then you have many questions which you would put forward to the patient instead of the patient put forwarding to you?
Yes, ma'am. All of us, we routinely see the patients who actually stop their treatment. Some patients they actually are doing well on the treatment, but somebody tells them that why are you taking these medicines? These are all got side effects. Your kidney will fail, your liver will fail, and they will stop the treatment. And eventually they will develop deformities. They will have bamboo spine, and then they will end up again back to the clinic with those, and then we can't do much when there is a complete fusion of the spine. I recently had a lady, she's in her 40s, she's not that old actually, she has been having this symptom for the last 15-20 years. She had seen another rheumatologist, was given proper treatment, and was advised for the further treatment in form of biologics because her disease was quite active, and actually she could afford that. The problem was why I felt bad is it was not the problem was not affording the medicine, not affording the treatment. She could afford that. She was from the well-to-do family, but because of misconceptions, she stopped the treatment. She stopped follow-up with the rheumatologist, and she went on taking some medicines from some place, some Ayurvedic or something, and her disease
Nachiket, are
progressed.
you online? Nachiket? Puneet, when you are seeing patients coming to you from rural India, uh, when they come to us every 3 months, what things do you tell these patients to come back with reports? Which reports do you ask them to come back with?
Yeah. So patients from rural India, so I think you should educate them a lot because they are easily they get prone, as Girish said, they get prone to alternate therapies and they are misguided. So I think that counseling is very important for them. Obviously, so we have to also take into account their financial aspect also. So depending upon what treatment they are on, we monitor the CBC or the CRP, inflammatory markers, and all those things, and the clinical examination. So regular clinical examination, measuring their of the flexibility, in terms of the shoulders and the chest expansion, all the other factors we look into. The regular follow-up is very important. Counseling, education is very important for them.
Dr. Pinto, would you want to add something?
So I think there is a problem. I think when we look at all our patients, I think there is a trust deficit. What happens is they go through so many people before actually reaching the doctor who is finally going to treat their disease. So they look at us with a lot of mistrust. I think that can be a lot of effort goes in the initial part to actually bridge that gap. And I feel that unfortunately, sometimes honesty does not pay. In this situation, when you actually honestly tell a patient that yes, all our treatment has side effects, may have rather, but most of the side effects are likely to be small. And the treatment is very good, but you're not going to get a cure. We see that a huge proportion, this includes highly educated patients who do not want to understand that the science behind the disease, do not want to appreciate the honesty of the doctor here. In fact, they expect us to just tell them that, sometimes you may actually get better results, I think, in practice if you just tell a patient, ke, abhi injection denge aur sab kuch chala jayega, rather than actually describe with honesty that you'll have to fight this disease with us and we will be with you through the journey. So I think, yes, that's where I think these awareness programs come in, where we discuss the science. The patient needs to understand that modern medicine, and that's why I insist that we call this modern medicine and not allopathy. This is modern medicine, and modern medicine is evidence based. It's not based on what I feel, what Dr. Girish feels, or Dr. Sabnis feels. It depends on it is based on what we have generated through trials, we've generated through observational data, and what we give them is the standard of care that they would get and they're able to get it at a minuscule of a cost, and they're able to get the doctor with a trained rheumatologist at a fraction of a price that they would have seen in a developed country. And I think very, very, very few people in India appreciate that this about our healthcare system.
Anisha, there's a question in the chat box where the patient has asked that if I skip medicines because of increased workload, should I meet the rheumatologist or go back to the same medicines again?
I think that would depend on how long the interval of skipping the medicines is and how severe their flare is. So, because skipping, sometimes patients who have very aggressive disease, skipping even 1 or 2 doses might lead to severe flares. So it might be worth checking in with their doctor and identifying if something can be done to bridge the gap. Because even if you restart your medicine, depending on what you're taking, it might take a little while to start working. On the other hand, if the gap is relatively small, you can just and you're all right clinically, I think you can resume your medicine safely, and but check in with your doctor at any time you have any doubts.
Smruti, do you advocate any vaccination therapies before you start the medicines
Yeah.
for ankylosing or arthritis treatment?
Yeah, for all the
And what are
patients who will be,
vaccines? What are vaccines? Let's give the patients a brief. Yeah, means which
yeah,
vaccines are the adult vaccines?
pneumococcal vaccine is one which we advocate, and even the quadriflu vaccine, which is a
For
very good
influenza.
vaccine, which is influenza, and it also has strains of
And the herpes
H1N1.
zoster vaccine is
H1N1,
coming
yeah,
by
and
GSK. Also, that is
yeah,
also
it's
going
still
to
not
be
available, but
advocated.
that
Yeah, it
yeah,
is coming this
it
month.
would be
And another important thing is the COVID vaccine. So I have told all the patients that it's quite safe to take your COVID vaccine. Only thing,
yes,
there are certain drugs to be stopped for
yes,
just 7 days after your COVID vaccination. So don't get scared and don't stop all your medications. There have been many
yes,
patients who have totally stopped their medications and their
yeah,
biologic
yes,
therapy because of the fear of COVID. Have you seen this, Puneet, in your practice?
Yeah,
yes,
so I have seen them not taking the vaccine because they are scared of some side effect of the vaccine because they're on the medicine. I've seen other way around also. And I've seen often what you are, I've also told.
but we need to
So I
sensitize all
think
our adult patients. We need to sensitize them for vaccination as well as a good protein diet, because with Indians the main problem is a low protein diet, and they have poor immune systems. So we need to sensitize them to have a good protein in their diet, as well as take care of your body with good exercise, and vaccination is of course important.
so. The bottom line of all this session today: first, go for a faster diagnosis. Go to a trained rheumatologist, because when we were taught during our medical training, we were taught ankylosing spondylitis as a total different disease compared to psoriatic arthritis or uveitis. I feel it is a part of the whole number line. I mean, I could have only spine involvement, any other patient could have skin with spine involvement, a third patient could have just plantar fasciitis or a pain in the any of the tendons coming to you along with the spine involvement. So different patients can come to us differently. Remember to take your medications on time. Do not skip your medicines. Follow up with the rheumatologist. Remember to take a balanced diet. Do not listen to other people unless it is scientifically authenticated. Remember not to Google and see the side effects. I tell people, आप डिस्प्रिन लेते हैं, डिस्प्रिन से भी bleeding हो सकता है. So why not take our biologics? Because the first thing they need is a lymphoma or a cancer or tuberculosis reactivation. So they are very scared to take a biological. It's not so. In fact, etanercept is celebrating its 21 years of biologic therapy this year, which is one of the first biologics, in fact, which I used when I started my biological practice. So do not get scared. We have seen side effects with biologics or JAK inhibitors, but not so much about significant importance. We have treated these side effects. So remember, go and meet your nearest rheumatologist in your nearby town. You have access to them compared to the Western world. It, I used to believe that we are the ones who take 8 to 10 years before diagnosis of ankylosing. But when I was discussing it with my European colleagues, in fact, they take 8 to 10 years before their diagnosis. So it's not so that we are very backward. In fact, biological therapy, whatever was available in 1993 when I started practice, used to come 5 years later down the line in India. Now it's not so. I think it's just the next month or maybe the next week that we see the biological coming in. So it's a total game changer which has occurred. So I think advances have definitely occurred in our therapies, in our training programs. We have more trained rheumatologists now. So remember, awareness is very important, as well as patient doctor relationship is also very important. So I also tell my junior colleagues to be more empathetic, more patient friendly, because then they will open up with all their past history or their problems. If you give just a tailor-made therapy to all patients, it doesn't help. So this is very important. I really thank all of you to make a Saturday evening free for all our ankylosing spondylitis warriors. Thanks, Anisa. Thanks, Dr. Puneet, Dr. Pinto, Dr. Smruti, Dr. Kulkarni, as well as Dr. Girish. Really a big thank you. And thanks to Zydus to sponsor us for Voice of Healthcare to be available to all our patients. Thank you very much.
Thank you, ma'am.
Thank you.
Thank you. Thank you.